Can you hear me well?
Can.
Okay. So you can look at this table. We just summarize everything we need to know about this IOTN. We have grade 5 on top, then grade 1 at the bottom. Grade 1 is no need, and grade 5 is a very great need. So if government service in UK and Malaysia, so if patient have IOTN more than grade 3, then we consider they are qualified for the treatment. Then if 1 and 2, then we try to pursue them not to do the treatment, or they want to do it, then they have to go to the private practice. Basically, it's just because our resources are very limited. We have limited order on this, limited material. So we want to focus those patients who really need the braces treatment. So if the patient fall into category 1 and 2, then maybe we try to turn them away. Then for this IOTN, they come up with a ruler. So this ruler, even though you don't have it, you still can do IOTN grading. Still can do IOTN grading. So you can use a normal rulers, but if you want to be fast, sometimes you have to get this ruler, and just to make your job easier. But without this ruler, you still can do it. This ruler is just simplify or summarize everything you need to know. You see on the right side, that's measurements, 1, 2, 4. That's more than 4. On the left side, there are overjet. You can measure the overjet accordingly. Okay, so when we grade this IOTN, then we usually trying to grade them according to this memoir, called MOCDO, MCODO, MCODO. So the M stands for missing T, then second O is for overjet, then the C is for cross spike, then D stands for displacement between the contact point, then the last one, which is overjet, overbite. So when you have let's say have a missing T and you have an overbite problem, then we take the missing T, because missing T according to this hierarchy, missing T will always come first. Then you have an overjet problem, then overbite problem, then you take the overjet, because the overjet is on top. Let's say you have a crossbite and overbite problem, then you take the crossbite. Displacement and crossbite, then maybe you take the crossbite also, but displacement and overbite, then take the displacement. So according to the hierarchy, So look at these rulers, these IOTN rulers. And on the left side, you have an overjet. On the right side, have displacement, overbite. So if you go according to the left-hand corner, on the top, so you see this, the top left is the overjet. So the first line is 3.5 millimeters. Second line is 6 millimeters. Then third line is 9 millimeters. Then the fourth line is 70 millimeters. Then the last one is 80 millimeters. Then if you reverse overjet, then you got the bottom left. The first one is a -1, then 3.5. So they already have the grading according to the severity. So let's say less than 3.5, then fall into the first. Is my slide hang? Okay, it's back. So to the top left, then if the overjet is less than 3.5, then with the category 2, category 2. Let's say 3.5 to 6, then it can be 3 or 2. So in competent lips, then it come to category 3 or grade 3. Then if the competent lips, then it fall into 2. And if it's more than 6 but less than 9, then the overjet fall between the 6 and 9, then you have grade 4. It's more than 9 millimeter, then it become grade 5. So if the reverse overjet, then -1, 2, -3.5, then it can be 3 or 4. Depends on they have a mastications or the speech problem. If the speech problem, then you upgrade 1. We're going to talk about it later. So you see for the 5 and 4, then the summarizer is summarized here. If the cleft lip and palate, then become 5, grade 5. Then have missing T, non-erupted or impeded, then this one become 5 also. Hypotonsia become 5. Then hypotonsia less extensive become 4. Crossbite more than 2 millimeter discrepancy, 4. Crossbite, then overbite individual trauma. Then on the right side, we have something less severe. So we just summarize everything, just make your job easier. And this ruler is developed by the Manchester University. But like I say, before you use this ruler, you can go back to basic, use the normal ruler. A normal ruler still can do IOTN grading, no problem. We'll come to that. So if you talk about discrepancy between the contact point, you can use these measurements. This one is 1, 2, 4. It's less than 4, then become 3. 2 to 4 become 2, then If more than 4 millimeters, become 4. Yeah. Okay, so this table again summarize everything we said just now, same with the IOTN rule. But this table you see, the overjet is 3.5 to 6 become competent lips, then become 2, fall into category 2. The 3.6 to 3.5 to 6, then incompetent lips, then the upgrade become grade 3. If 6 to 9 become 4, then it's more than 9, it become 5. So 2, 3, 4, 5 depends the overjet. Then if you reverse overjet, same thing. Less than 1 millimeter, grade 2, 1 to 3.5, then grade 3, then more than 4, it become grade 4. And more than 3.5 become grade 4. Okay, so this reverse overjet, I just want you to pay attention. This B and M, similar. B and M is similar, both also reverse overjet, but one is a problem with speaking and mastication or chewing. The other one without any problem with speaking and chewing. So if either one problem, they have problem eating, they have problem speaking, then they fall into category M. So for example, so let's say you have 1.1 reverse overjet, 1 to 3.5, but have a problem with speaking and eating, then straight away the upgrade to 4M. From 3, the upgrade to 4, but the alphabet will become M. This one is B, then M is with mastications on the speech problem. So you see the right side, this one, 3, minus 1, 2, minus 3.5. If the problem speaking, eating, then upgrade to 4. But the alphabet change to M. Same, if you're more than 3.5, reverse overjet. If the problem speaking, eating, then the upgrade another level to 5. Then it become 5M. So a problem with the speaking and eating, then the upgrade, then they change the alphabet to M. Crossbite, be very careful. A lot of people, they just measure the crossbite, how much crossbite is. It's not accurate. If you look at the definitions, the crossbite must have discrepancy between the ICP and the RCP. ICP in the cuspal position, then the RCP retruded cuspal position. So the patient must have initial contact. They must be able to bite cups to cups, then before the jaw or the teeth shifted left, right, forward, and backward. Then this discrepancy between the ICP and the RCP, if they're less than 1, then they fall into category 1, 2. Then if they're 1 to 2, then fall into category 3. Then more than 2, then fall into category 4. You might ask why they didn't have this more than 2 millimeter. What happened if more than 2 millimeter? If more than 2 millimeter of crossbite, then this patient mostly have a reverse overjet. Then we will classify them into the category of overjet. So same thing, tooth displacement or crowding is a very basic problem for braces. So when you see the crowding, less than 1 millimeters, then grade 1, then 1 to 2 millimeter, grade 2, then 2 to 4, grade 3, then more than 4 millimeter, then grade 4. Same with the open bite. You see the measurement, same with the open bite. 1 to 2, 2 to 4, and then more than 4. So displacement and overbite is similar, but they come with the category, the alphabet difference. Displacement is D, then overbite is E. Overbite is E. Then, open bite is E. Then we have overbite, which is a deep bite problem. So according to our definition, if it's less than 3.5, then consider normal. So then if more than 3.5, then 2 to 3 millimeters overbite is considered okay. If more than 3.5, then consider a bit deeper than average. So incomplete, no trauma, then they are grade 2. If they are increased, they have the contact, but no trauma. It means they have contact, means the teeth touching the palates or the teeth, but not causing any indentations or trauma, gingival stripping, then consider 3F. If they increase complete and causing any damage to the gum, the teeth, then consider 4F. 4F. So this one pre and post normal occlusion, we are going to talk about this. But basically, it just means there are no perfect interdigitations for the buccal segment. So you see the buccal segment is like zigzag. So they have to occlude nicely in order to get a perfect bite. So without this zigzag or perfect interdigitation, then we can classify them as a 2G. And hypodontia is the less severe one, less than 1-2 per quadrant, and consider 4H. 4H. So if more than 1-2 per quadrant, which usually need the restorative specialist to come in to fill up the gap, then consider 5H. More than 1-2 per quadrant. Impeded eruptions. It means the tooth is not visible. The tooth cannot be seen in the mouth. Consider impacted. Can be due to crowding, again with displacement of other teeth, or it can be due to pathology, cyst or whatever. Then this consider 5I. Posterior lingual crossbite. There are no functional occlusion. Then we give them 4L. Then after that, if a reverse overjet, like I say, if there are previous reverse overjet investigations and this speech problem, then we upgrade to 4 and 5. If the cleft and palate, then straight away they will get a 5P. Submerged T, if the mainly deciduous D and E, submerged below the contact point, then we give them 5S. But let's say they have a crowding, but the tooth is not impacted. They are erupted partially, but they are stuck. So we give them 4T, partially erupted or tilted against each other. Then we give them 5T. If they're totally invisible, then I give them 5I. Either 4T or 5I, depends, they are visible now. Then if they are supplemental, supernumerary, then we give them 4X, okay? Okay, so each of 5 categories is subdivided and given a letter. So those letters will just give you the idea what's the problem. For example, A is overjet, then B is reverse overjet. Let's say I give you 4A, instantly you know this patient have an overjet problem between 6 and 9. So when you call me up, you say, okay, Dr. Ma, I have a patient, have an IOTN 4A, then in my head, or I can picture the patient have an overjet problem, which is between 6 and 9. And if you tell me I patient IOTN is 5A, want to refer to you, then straight away I know this patient have an overjet problem, more than 9 millimeters. That's how we summarize the case and give you a rough idea what's the problem for this patient. So you give me 5I, I know that's impacted too. So even though the IOTN is not perfect, but they just give you the rough idea what's the patient problem. And according to the severity of the problem, they grade them 1 to 5. But when you grade the IOTN, you only choose one, So you choose the most severe trait. So let's say patient have a 3D, then you have a 5A, of course you go for 5A rather than the 3D. So you always go for the most severe category or the most severe grade. So for 5, we have a overjet problem, then we have a reverse overjet, hypodontia, severe hypodontia, cleft and palate. Then we have these impeded eruptions, impacted tooth, and we have the submerged deciduous. So these 6 category. So we look at this overjet first. This overjet, then more than 49 millimeters, consider severe overjet. This one will become 5A. Okay, you see how much the overjet is. So this one is severe overjet problem, then become 5A. So if you have reverse overjet, more than 3 millimeter, plus the difficulty in speaking and eating, then that become 5M. If there are no problem for eating and speaking, then it become 4B. Okay. So for this one, reverse overjet, more than 3.5 millimeters, then patient cannot speak very well. Certain food they cannot pronounce properly. They have problem eating, like biting noodle, cutting noodle at the front. Then consider eating problem. Then this one become 5M. So let's say if the severe hypodontia, they have more than 1 tooth missing per quadrant. So you can know, braces very common. We extract 1 tooth per quadrant. So mainly is the premolar. Then we can close the gap. So the gap is 7 meters. 1 premolar, the width is about 7 millimeters. We can close it with braces without problem. But if it's more than 1 tooth, the size more than 1 tooth, and it's going to be a problem. So usually braces cannot close it. So if more than 1 tooth, then we need the restoration. Whether they need a bridge implant or denture. So we have more than 1 tooth missing, and patient become 5. So this side is 5H, 5H, more than 1 2 per quadrant. So you can see this patient missing lateral incisor, then missing premolar, more than 1 2 per quadrant. So you're just missing lateral incisor, maybe it become 4H, right? More than 1 2 missing per quadrant, then become 5H. Same with this one, you see the premolar is missing, maybe 4 and 5 is missing, 2T per quadrant, consider 5H. Oh, sorry, repeat. Okay, so you can double check the X-ray. Sometimes they're impacted, you don't know. So you need the X-ray to verify whether they're missing, impacted. So you have to look at the X-ray. So on this X-ray, you can see the 4 and 5 is missing, and the 2 and the 4 also missing. Oh, sorry, 2, 4, 5 also missing. So it's 3 here on this quadrant. So this patient will be 5H. The IOTN will be 5H. So cleft and palate, we talk about this, very easy to recognize. Lip, palate, cleft, then consider 5P. Why the cleft patient will classify as the most severe trait? Because there are so many. They are crowding, they are missing teeth, then the displacement, reverse overbite. So many problems. So if the cleft, then straight away they become the most severe, which is 5P. 5P. So cleft, lip, and palate, even though the repair is still classified as 5P. 5P, you can see the cleft, there's so much a problem. So this one have missing lateral incisor, then crowding. So impeded eruptions impacted, it means it's not visible in the mouth. So mainly it's due to the lower 5, the last one to come out, not enough space, or it can be upper 3, impacted canine. This one is the most common. For braces, we don't take this impacted third molar as a 5i. Impacted third molar is not considered the braces problem. So usually we don't say 5i is due to the impacted third molar. We exclude the third molar. So we only focus on 7 to 7 for this impacted tooth. Okay, submerged decidus, like I say, I usually consider submerged if they bypass the contact point between the adjacent tooth. So let's say it's an E impacted, submerged. And if they bypass the contact point between the 6 and the premolar, they come below this contact point, I consider it submerged. It's okay. So if you have grade 4, they have an overjet problem, then reverse overjet, then cross bite, displacement, then anterior open bite, then posterior open bite, deep bite, then posterior lingual cross bite, hypodontia, reverse overjet if they have a problem eating and speaking. Then 4X is supernumerary, then 4T are partially erupted tip T. Okay, first one, reverse overjet. You see, I highlight this both. So they have a problem with mastication and eating, then they jump to 5M. If there are no problem, then they remain in the 4B category. So if you're 1 grade lower, but they have a problem with eating and speaking, then they will become 4M, even though that reverse overjet is not severe. So this one, always remember, if the problem with eating and speaking, they jump upgrade to 1 severity, from 4 to 5 or from 3 to 4. That's because they have a eating and speaking problem. Okay, supernumerary present, then partially erupted. So impacted too, you have to be careful. They are considered 40 if they're partially erupted. Let's say you can see the tips or the crown partially, then not consider 5i, they consider 40 because they are partially erupted, tip, and impacted against the adjacent tooth. So this one, same case, you see same case. If you have no problem with speaking and eating, then they fall into the 4B. If there are problem with eating and speaking, then they become 5M. Simple. So crossbite, again, like I say, they must have a discrepancy between the ICP and the RCP, more than 2 millimeters. It can be anterior. You see this patient, they manage to achieve the H incisor, then only the jaw will move forward or displace forward. You see this initial contact on the central incisor, then they displace the jaw forward. So you can measure this overjet. So this reverse overjet is more than 2 millimeters, then it consider 4C. 4C. So that's how you classify ICP and RCP. Okay. So displacement, again, is a bread and butter for braces. Crowding, so crowding is the most common thing, but it doesn't score 5 because crowding is considered very basic. You do braces because of crowding. So the most you can qualify is 4, severity 4. Then we use the capital D. So 4D displacement, more than 4 meters. For example, I see the contact point between the lateral incisor and the canine. So the contact point is here, then it's here, then this contact point more than 4 millimeters, then consider 4D. Same for this one, lateral incisor and canine, more than 4 millimeters contact point, so consider 4D. Again, 4D, when it comes to severe crowding is always 4D. They are not 5D, only 4D. Okay, anterior open bite, same with the displacement. If the anterior open bite or posterior open bite, they are more than 4 millimeters between the incisor edge. So measure between the incisor edge. Let's say this one central incisor, between the central incisor edge to the bottom. This one is more than 4 millimeters, consider 4E. So if you measure this lateral incisor less than 4 millimeters, then this one more than 4 millimeters. Of course, you take the 4 millimeters, more than 4 millimeters. Like I say, you always take the most severe one. This one is not that severe, you ignore it. You take the most severe one, which is more than 4 millimeters in this case. So this patient should be 4E. 4E. Deep bite, this one have to have a gingival indentation or trauma or stripping of the palate. Then this one considered deep bite with the trauma. So you see this one, deep bite, causing gingival strippings on the palate. So this one, if you leave it long enough, it cause sensitivity, or sometimes it may cause the devitalization of the tooth. So have to be careful. Be careful. When you see indentation, even though they are not causing any stripping yet, that is considered a deep bite with the potential of trauma. So you have to deal with that fast before they cause any stripping. Once this stripping is happened, even though you reduce the overbite, this might not help the gingiva to come back. Whatever caused the damage, it might not be irreversible. So you have to be careful. When you see the deep bite, then maybe you try to act fast before it cause any damage to the gingiva. So posterior lingual bite, we are not talking about 1. No, not talking about 7 is in lingual crossbite. We are talking about a full segment. Full segment, usually from 4 to 7. The whole segment is a lingual crossbite. So this one consider 4L. Supernumerary. So supernumerary very simple. We just count the 2, whether they are more or less. If the less become H, or 4H, 5H, and if you are more than 1, as more than the full set, then consider 4X. For this one, mesial dense, we consider 4X. Partially erupted against the adjacent 2. Like I say, impacted 2, let's say they're erupted. Over 5, they're erupted. Then there are impingings or they are tilting against the next adjacent 2. And this one consider 40. Okay, then we have a category 3, then which is less severe. We have an overjet 3.5 to 3.5 to 6 or more than 3.5. Incompetent lips. So you see 3A and the 2A, they're similar. One's incompetent lips, then the other one incompetent lips. So to differentiate the 3A and the 2A. Then 3B is a reverse overjet 1 to 3.5. So this one, if they have a mastication or eating problem, they become 4M. 4M. If there's no problem, then it becomes 3B. Displacement 2 to 4 millimeters, not too severe. Become 3D. Then we have open bite, lateral open bite. So this one deep bite also, but no traumatic bite. I mean, they're not causing any damage to the gingiva of the teeth. So this one reverse overbite, reverse overjet, then they're not too bad. Then this one anterior open bite, not too bad. And then this one deep bite, not causing trauma. So two is very mild, very mild. So this case usually we reject in the government service due to the limitation of the resources. So the first one is 2B, overjet less than 1 millimeters, then displacement 1 to 2 millimeters, anterior open bite, posterior open bite 1 to 2 millimeters, then increase overbite more than 3.5, but without any gingival contact. They're not complete, they are not causing damage. Even though they are deep, they are not causing damage. Or the 2G, 2G is a pre-normal or post-normal occlusion with no other abnormality. Let's say the patient everything look not nice and straight. It's just a bucket interdigitation is not perfect. Then maybe we categorize them as a 2G, up to half unit discrepancy, up to half unit discrepancy. We're going to talk about it later. So for this one, reverse overjet, not too bad. And this one deep bite, not causing any occlusal trauma. Okay. Then this one again, open bite, not too severe. So grade 1 usually extremely mild occlusions, extremely minor. So this kind of patient, I would say even private, I try not to do it. Because imagine this kind of mild occlusions, maybe a little bit overbite, reduce, then this patient, minor rotations. If you do braces, then you subject the patient into the permanent retentions. Are they going to wear the retainer for life? It's just because they want to correct this mild occlusion. So maybe not worth it, So when it comes to a very minor problem, then you have to tell the patient what's the risk and benefit before you do the braces. So my personal opinion, if you want to correct these mild occlusions, just a minor thing, then you want to subject the patient for lifelong retentions, then maybe it's not worth it. I'd rather you have a healthy teeth and live happily. Yeah. Okay. So aesthetic component, again, this one not my favorite because I think this one very subjective. I think we discussed this before. So usually they try to take away the colors when you're creating the model. Then if you're creating the patients, then maybe you have put the colors in. So this one with the color. So you just retract the patient's lips, left and right, using the retractor, or you ask the patient to give you a big smile. Then you just get the first impressions. Then you compare with this chart. You just grade the patient accordingly. So this one, the left side, they have a purpose. When you grade the patient just using the study model, you don't want this color to take your cause your bias. Then maybe you just take away all the colors and use this chart without the colors, then look at your study model, then you can grade the patient better rather than you have these color pictures. So again, very subjective. Whatever you think might not be whatever I think. Then whatever you think might not be the patient think. So this one, we can argue. So for example, this one, I think last lecture we talked about this. Some people will grade 5, 6, 7. Some people might grade maybe just 3. So this one, very subjective. But I would suggest the first impression is usually correct. So you look at this picture, then you grade it, the first impression. Once you look at all the detail, then you'll lose the focus. So I think this one maybe 6 or 7. I think they're okay. Moderate crowd. So 1 to 2 is considered no need. Then 3 to 4 is slight need. Then 5 to 6 and 7 moderate. Then 8 to 9, 10 is considered severe. Okay, so dental health component is widely used, but aesthetic component, again, not many people using it because there are too much of variations. Okay, cast 3. Okay, look at this photograph. They have limitation. Look at all these mild occlusion. None of them are cast 3. None of them are cast 3. So when you want to grade the patients having the cast 3 skeletal pattern and mild occlusion, sometimes it's not accurate because they only take the class 1 and class 2 photograph. Okay, so I think I finished IOTN, just a lecture briefing. Then I look at something else. Okay, so just now we talk about Mokto. Mokto in the same category, let's say 5A, then 5I, then which one should you choose? So you use this Mokto as a memo, then you according to this alphabet, then you know which one you should choose. Let's say you have a missing tooth, 5H, and then you have an overjet problem, 5A, then you go for 5H. Because missing tooth will come first. Number will come first, then followed by overjet, then crossbite, displacement, the last one is overbite. Okay, so hierarchy scale, then which features should be recorded. Okay, so let's say missing T, overjet, crossbite, displacement, and last one is overbite. Then equal to Mokto. So first we talk about missing T. Let's say missing T, the congenital missing. This one is just repeating whatever we said just now. So it can be due to congenital missing, impacted, which is inside, it's not erupting, or impacted, then partially erupted. So usually, impacted to if the 4 millimeters less the space available between the adjacent two. So you might ask, what happens if you have 5 millimeters? So 5 millimeters, most probably the two is already erupted or partially erupted. So they consider 4T rather than 5I. So this one usually less than 4 millimeters, causing the impaction. Then we have this 5H, which is the hypotential impacted. This is all about number, missing T, the alphabet M, and even erupted, 4X, extra T, or submerged, we consider number also. So we have overjet problem, then we have reverse overjet, positive overjet. So positive overjet, then we give a 5A, 4A, 3A, then reverse overjet can be 4B, 3B, then we have mastication and speech problem, then we give them an M, alphabet, M. So how you measure the overjet? So overjet I measure using a ruler. So you held parallel to the occlusal plane. You shouldn't tilt it. No, you don't tilt it up and down because the measurement can be wrong. So you have to parallel to the occlusal plane. So you record it on the labial surface of the incisor, or the upper incisor, lower incisor, use the labial surface. That's how you measure the overjet. So the overjet, reverse overjet, only measure if the lower incisor, 4 incisor are reversed. If one incisor reverse, they are not considered reverse overjet. Also pretty consider cross-bite. So this picture, it just summarize what we said just now. The measurement should be incisor labial surface to incisor labial surface. That's how we measure the overjet. And this ruler must be parallel to your occlusal plane. Don't tilt it up and down because the measurement might change. Okay, so I might ask, if sometimes if the left and right incisor, then maybe one will give you 4 millimeters overjet, the other one give you 9 millimeter overjet. Which one should you take? You take the most prominent incisor. Which one stick up more, or which one you reverse overjet more? You take the most severe one. So of course you can use this IOTN ruler if you have it. That's how you measure also. You just put a ruler parallel to occlusal surface, then see with the 2 incisor edge which line it fall into. Then you know there are 2, 3, or 4. For the example, you see the incisor, it fall into category 2. So this one is 2A, 2A. So reverse overjet, same thing, from the labial surface to the labial surface, the incisor, then the ruler must be parallel to the occlusal plane. So for this reverse overjet, you see the lower incisor will fall into category 4 or 5. So if category 4, then if there are no problem for eating and speaking, then we have to 4B, 4B. But if there are problem for eating and speaking, then it will become 5M, even though they are same measurements. 4 and 5, it depends. They have a problem eating and speaking or not. Crossbite. Okay. So it can be anterior, posterior, but mostly posterior. Then check for displacement on closure. Anterior, less than 40. Then if more than 40, we consider reverse overjet. Posterior cups to cups or in the full crossbite. So you see this one, only single 2 in the crossbite. So this one not consider reverse overjet, only consider crossbite because there are only 1 or maybe 2 lower incisor is involved. So same thing, this one maybe 1, 2 involved, we consider crossbite. This case, I think we saw before this case during our case discussion, same case, the class 3 case. Lingual crossbite, the full segment is in the scissor bite, we consider 4L. 4C. So 4C is a crossbite between the ICP and the RCP have a 2 millimeter discrepancy or more, then consider 4C. Means patient must be able to bite cups to cup, then maybe the jaw will deviate to the left, right, forward, or backward. It's more than 2 millimeter discrepancy between this RCP and the ICP. Then consider 4C. So this picture we saw it before, have a forward displacement. Then we come to the displacement, which is the second last. You see displacement, according to Mokto, they are not the first one. They are not the first one to come into mind. They are the fourth displacement. So crowding, like I say, is very common for braces. Every day we deal with crowding. They are not considered the most severe problem. We can easily correct it or rectify it. So only apply to the crowding between the permanent teeth. It's not applied to your adult, to your mixed dentition or your deciduous to the adult. Must be adult to adult. So measure between the contact point of the two most crowded teeth. So you take two most crowded. It means that they displace the most between the contact point. You take that two particular two, then you measure the displacement. So forget about all those minor crowding. Take the most severe one, then you measure the contact point displacement. Then that's the finding. So displacement between the deciduous and permanent teeth are not recorded. So deciduous teeth we ignore. So like this one, contact point is here, upper left one, and to the lateral incisor. Can you see my slide?
Yeah, now can. That's okay.
Huh?
The mouse, right?
You see the slide with the occlusive view?
Yeah. But
okay. So you see this one, upper left one and upper left two, they have a displacement between the contact point and contact point is more than 4 millimeters. This one consider 4D. 4D. It's more than 4, so we consider 4D. Okay, you see this ruler, IOTN ruler. They just this one 1, 2, 4. This one more than 4. So according to this severity, grade 1, grade 2, grade 3 is more than 4, you consider 4, 4D. Less than 4, between 2 and 4, you consider 3D. Less than 2, 2D. Less than 1, 1D. Okay. So of course, without this IOTN ruler, you still can measure it using the pedal probe or the normal metal rulers. You still can do it, no problem. You still can do it, no problem. So the last one is overbite. Overbite.
I think the slide
causing gingival and palatal trauma. Yeah?
I think the slide is not moving. Okay.
Lagging.
Yeah.
Okay. Lagging. Okay. Maybe I just logged out. I come back. Can see my slide?
Yeah, can.
Okay. So the last one is overbite. Deep overbite, then become 4F. This one we talked about this before. Deep bite, always check whether it have occlusal trauma to the teeth, to the soft tissue, or the palate. So even though they are not causing any stripping yet, I can see the indentations. So that's considered potential trauma. So we have to act something. We have to do something, act fast before it causing more trauma. And then posterior open bite. So it's measured from the incisor edge to the incisor edge. Take the most severe one, the overjet the most. Take the incisor edge, or from the cups tips to the tips, from the buccal cup tips to the lower cup tips. So for this one, you can use a pedal probe to measure from the incisor edge upper to the lower. Of course, you can use this IOTN ruler. You still can measure it according to this. So this one is more than 4 millimeters. This will consider 4E. So discussions. So if the Barker occlusion in the good Barker segment, the canine premolar and molar interdigitate fully regardless of whether they are class 1, class 2, or class 3, but they are fully interdigitate. It means they have a zigzag, then the O fall into a nice place, then they are considered okay. But let's say any of these T is deviated from the full interdigitation, then they have a grading, called 2G. So you see this one in these pictures, you see the canine, premolar and molar, even though this one is considered class 2 molar, but you see the canine is considered class 1. So they fall in between the embryo nicely. So this one considered perfect interdigitations, even though they are molar class 2. Compared to the right side, you see the right side, this one is considered imperfect interdigitations. You see, even though they're class 2, these cups not fall into the embryo. They don't have the zigzag occlusion. So this one will give them 2G. So impeded eruptions, if the tooth is erupted due to the contact or close approximations, it means they are crowded, then the dental health component can be 5I if they're not visible, unerupted. But let's say they're erupted, but they're tilted or they're stuck, then we give them other thing. If they're erupted, they are not stuck, then we give them displacement, 3D or 4D, which is crowding. But let's say they are stuck and they're causing tipping to the other T against the other T, then we give them 4T, rather than 5I. So 5I must be totally invisible. Then the impacted come out slightly, but they're tipped against the adjacent tooth, we give them 4T. Okay, displacement. You see this one, displacement, even though they're crowded. Okay, you see this one, the left side, maybe this one consider 5I. Don't consider 5I. The right side also 5I, because they are totally impacted, cannot be seen in the mouth. Spacing. Spacing can be a problem for braces, but unfortunately, this spacing is not generally recorded for this dental health component. So IOTN, they have limitation. Spacing doesn't score anything. But do you still have to treat the patient? Yes, because spacing can be an aesthetic problem and it causes foot stuck, aesthetic problem. So we still have to treat the patient, even though they didn't score anything for aesthetic dental health component. So is spacing associated with the T deviated from the line of the arch, then the contact point displacement is recorded. So let's say space arch, they have spacing between the 3 and 4 or 4 and 5, even though they are spaced, but they have the displacement or the contact point. One is front, one is back, then it still score for the displacement, even though they are spaced. So, but if the T has been extracted, then the space is not recorded. So extracted T is not considered for IOTN. Yeah, so you have to take the X-ray and the history properly. So you see this case, so even though they are spaced, so maybe displacement on the contact point on the 3 and 4 is still considered displacement, this one. Of course, you can take this one, you score your displacement, maybe you score 3D or 4D. But let's say without this premolar crowding, you still can score something between the canine and the premolar, even though they are spaced, because they have displacement between the contact point 3 and 4. Spacing, this one score nothing, space. So submerged decidus. Submerged decidus are not recorded unless only 2 cups of the tooth remain visible. So they must be submerged to a certain extent before you can score something for the 5S. So for this definition, the tooth must be submerged. Then let's say we take the molar decidus as a sample. So we have 5 cups. So it may submerge deep enough until they have only 2 cups visible. Then consider 5S. So the adjacent teeth are severely tipped towards each other. It means one is submerged, then adjacent tooth will tip into the space, then they consider 5S. Doesn't mean they are a little bit submerged, then you consider 5S. So you have to go for the definitions. So usually the simple one, we just tell them whether they have a submerged below the contact point. If they're below the contact point, then most probably the adjacent tooth will tip into the space. Then they will give you the 5S. So if they're above the contact point, then most probably the adjacent tooth is not tipping into the space. Then they're not considered 5S. That's how I grade them easily. So you see this X-ray, you can see the adjacent tooth tips into the space. And this one is totally submerged. Maybe you cannot see it at all. So this one considered 5S. This one also the same thing. You see this one submerged E, and causing the tipping of the adjacent tooth into the space. And this one, I think you can give them a 5S. So let's say this one, okay. This one is submerged. Yeah, this one submerged. Maybe, maybe you still can see the other cups. Then maybe you won't give them the 5S. So what are the limitations? Even though we take the patient occlusions or malocclusions for the grading, but you didn't take the psychological component, the awareness of the patient, then the patient's demand for the treatment. So you didn't take this as a consideration. So even though some patients have a severe malocclusion, but sometimes they doesn't want the braces, they don't want to fix it. So if you tell me the patient have a 5A, doesn't mean the patient want to fix it. If they doesn't want to fix it, is that a problem? Maybe it's not a problem. As long as they're happy that they're not causing any impact or the trauma to the front inside, so then there are no case. So we didn't take the psychology the component into considerations. So the need for treatment does not necessarily equate to the complexity of the treatment. Like I say, even though they are 5A, even they are 5P, cleft patients, like we mentioned in the last lecture, they might not want treatment. So if they don't want treatment, then maybe it's no case also. So the complexity of treatment doesn't reflect or equate to the necessity of the treatment. So this I have to be careful. So using the IOTN or the DHE, dental health component, some minor irregularity may not score very well. Like for example, the spacing does not score at all, but you still have to treat the patient because it's still the need for the patient. So aesthetic component take account of the teeth only and not the teeth within the face. Sometimes you see the teeth are very straight, but when patients smile, they are severe gummy smile. So it doesn't show in those pictures. So you cannot score the patient even though they have gummy smile. Straight teeth, class 1, gummy smile. Do we have to treat the patient? We still have to treat patients, but the teeth are already straight. So sometimes this aesthetic component, it doesn't reflect what's the patient's problem. So for example, this one, they have a retained decidus. Then for IOTN, it's called nothing. But still have to do something. You have to take out the decidus, let the median diastema close, even though it's called nothing. So this one I talk about it. This table, I think I showed you before just now. Just summarize everything we said just now. Okay, so when we come to confusions, let's say a 5A, 5H, or 5I, then you go for this motto according to the sequence or hierarchy. Missing T always comes first, overjet later, then crossbite the third, displacement or crowding fourth, then overbite is the last one. Overbite is the last one. Okay, forget about this ruler. We don't have it in master, but I still can use a metal ruler to do it. Okay, so summary, the IOTN have the advantage of quick and easy to use. You tell me 5A, I know they're overjet. You tell me 4X, I know they are supernumerary. You tell me 4D, I know the displacement. But you have to be careful. There are limitations, like we said just now, the psychology part, and sometimes it doesn't reflect the patient whether they want treatment or not. So there are so many limitations for IOTN. You have to use it with care. Okay. So what if you're talking about you want to use the IOTN without the patient present? It means you only have a cast, like I show you the 30 cases, which you're going to do later, but without the patients. So what are you going to assume, or what are you going to grade the patient IOTN? So there's some protocol. Let's say you measure in the dental cast, the overjet is between 3.5 to 6, but you don't know they're competent lips or not. Then you always grade them the worst. You assume the patient have incompetent lips because you cannot see the patient clinically. So based on the study model, you go for the worst. So you never miss. If you go for the 2A, then patient might be qualified for the dental treatment for the government service. So you click them 3A, then maybe patient can qualify. So if you're not sure, then you go for the severe one. You're not sure the competent lips or incompetent lips, then you click them the incompetent lips. So the dental crossbite in the dental cast, let's say crossbite, you cannot check whether they have a displacement or discrepancy between the ICP and the RCP, because you cannot ask a patient move the jaw backward or forward. It's based on the cast, then you just assume they have a discrepancy between the ICP and the RCP. It means you have initial contact with the displacement. So you give them the 4C. If you only have the dental cast without the patient present. So reverse overjet, let's say you have reverse overjet, but you do know patient have a problem speaking or eating or not, then you give them, again, the most severe category. Let's say they have a 4B, but you don't know whether they have a problem with speaking or eating, you upgrade them to 5M, give them the most severe one. Then 3B will become 4M. Then 4B will become 5M. Okay. So maybe we do some exercise together before we jump into the 30 cases I give you. So what do you think this case? So these patients, the first thing you have to do is they have to count the teeth, whether they have a normal number or they have a less or they have more teeth. So you count the number, then the best thing is to do from the occlusal view. So you count the number 1 to 7, 1 to 7, then 1 to 7, 1 to 7. So you got all the teeth present. The only thing maybe have a crossbite on the left. So crossbite on the left, you measure this reverse. So you measure the overjet, maybe more than 2 millimeters or between 1 to 2. Then you assume maybe it's a 4C or 3C, because a crossbite on the right side. Even though you cannot check the ICP and RCP, but based on this, maybe you just assume they have a displacement, maybe 4C or 3C. Agree? For this case?
Yes.
Okay, all right, okay. So this one may be the overjet problem. Already status, overjet is 8 millimeters, incompetent lips. So 8 millimeters, which will give you category 4A, 6.5 to 9 millimeter, incompetent lips. So this one maybe we go for 4A, agree? Or you have other? Okay, maybe you can argue there's a deep bite, deep bite. But if you go for Mokto, which one will come first? Overjet or overbite?
Overjet.
Yeah, overjet. So this one we will, according to the IOTN, Mokto, then we give them 4A. Agree? 4A?
Agree.
Okay, good, good. So if you disagree, then you tell me, then we can discuss further. Okay, how about this one? Class 2 tip 1, upper lower crowding. Okay, left side and right side, molar relationship is not the same. So what do you think this one? First thing, count the teeth. 1, 2, 3, 4, 5, 6, 7. Okay, same. Okay, you have all the teeth present. Okay, then you go according to the mouth occlusion, deep bite, overjet, other thing, crowding. So what do you think in this case?
4D.
4D, I agree. Displacement between the lateral incisor and the canine. This one will score 4D, more than 4 millimeters. Even though the lower between the lateral incisor and the canine, that will give you the 4D, more than 4 millimeter displacement between the contact point, 4D. Agree? Everyone agree? No disagreement. If you disagree, then you let me know. Then we can explain and go through it together. Then how about this? Upper lower crowding. First thing, count the T. 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6. Okay, all the T are present. Then look at other features. So what do you think in this case? So this one maybe it's again crowding, 4D.
Yes.
Okay. All right. I think my computer is out of power. Just let me get the power extension first. Take a break. 1 minute. Okay. All right. So now we go to the next case.
Doctor,
Yep.
one question.
Yeah.
What's the difference between cross-bite and reverse overjet, anterior cross-bite and reverse overjet?
Okay. Just now we already talked about this. Reverse overjet, 4 incisor. The lower incisor must be in the reverse bite. You see, if you have only central incisor, they are in the reverse bite. That's not considered reverse bite. So you have to be 4 incisor, the lower incisor, 4 lower incisor in the reverse bite. Then you consider reverse overjet. So you have only 1 or 2 incisor in the cross bite, then maybe they give you C, 4C or 4D, 4C or 3C, rather than you have a 3B or 4B. So reverse overjet must involve 4 incisor, because we are looking for the class 3 malocclusion. Yeah.
Yes, understood.
Okay. All right.
Another question.
Yep.
If the patient has a severe crossbite but minor overjet, so which do we go for?
Severe crossbite.
But very minor overjet, but overjet comes before crossbite, right?
Yeah. You see, if you have minor overbite, it means the reverse overbite.
No, a minor overjet but severe crossbite.
Minor overjet, which is how many overjet?
Like for example,
Okay, let's say less than
one
3.5.
Oh, okay.
Okay. Less than 1. Okay. That maybe you give you a 3B, yeah, less than 1 millimeters, 3B, or 2B. Okay, let's say we talk about 2B, 2B. So you got reverse overbite, reverse overjet, but you have a 3C. So you're going to choose 3C rather than the 2B, because 3 is still more severe than 2. So first, you go for the 5, 4, 3, 2, 1, the severity of the malocclusion. So you have a 5C, 5A, and let me see. Okay, you have a 3B reverse overjet, but you got a 4A overjet. Sorry, no, 5. Okay.
Basically, we go for the more severe one.
Yeah,
right?
the most severe one. So if you're 5, then of course you go for the 5. But let's say in the 5 category, you got 2 features overlap. Let's say you have a 5I, then you got a 5A. You got 2 to pick in the same category. This patient have impacted and they have same time have an overjet problem. Then you go for the Mocto. Yeah. But you have 2 category, 5 and 4, of course you go for the 5, no doubt. You have 5 and 2, then you go for the 5. 4 and 2, you go for the 4. 3 and 2, you go for the 3. Just that in the same category, all also 3, then both also 4, then we come to overlapping 2 category 4, then go for the Mocto. Yeah.
Okay, understood. Thank you.
Okay. All right. Okay. Have we talked about this case? Have we done this case?
Yes.
Okay. So we agree this one is 4D. Yeah, 4D. Okay. All present, just a severe crowding. Yeah. Okay. So maybe you can argue this one crossbite, maybe you will cause some displacement. Okay, maybe. Maybe you can go for crossbite if the patient has displacement. Okay, how about this? So this we have all the teeth present, but it's just a narrow arch. Then both sides slightly class 3. Then reverse bite on the 1-2 and the 2-2. Then tenuous overbite overjet on the central incisor. So what do you think this case? Anyone want to try? Maybe you can talk about this displacement crowding between retro incisor and canine. That will give you 4D, maybe more than 4 millimeters. Or you can talk about this crossbite. Let's say assume this crossbite is more than 2 millimeters, which will give you 4C. So now we have a 4D and 4C, maybe. Okay, which one will you choose?
4C.
Why 4C?
Mocto.
Yeah, Mocto. So that's what I mean. If you have 2 category 4, then go for Mocto. So even though we have a displacement and a crossbite, the crossbite will come first before the displacement. So Mocto first missing T, then overjet, then the third one cross bite, then displacement. Finally, it will come to overbite. Okay. All right, everyone agree this one maybe 4C if there are displacement. If no displacement, maybe I give you 4D. 4C or 4D, depend on the displacement. Oh, you see this one? I written here without displacement on the bottom right. So this one, even the cross bite without displacement. So maybe this case we will give 4D. Agree? 4D?
Yes.
Okay, 4D. All right. How about this one? Upper lower crowding. First thing, count the T. Whether they have missing T. Okay, all present. Okay. Okay, number no problem. Then go for other features. Maybe this patient have a displacement. Central incisor and lateral incisor, 1, 1 and 1, 2, displacement. This one maybe more than 4 millimeters. Maybe give you 40. And look at the bite. This one is deep bite, maybe causing indentations. I see already written here, complete and traumatic to the palate. So this one have a deep bite and traumatic, and at the same time have displacement and crowding. Class 2, deep 2. So which one you go? 4D or 4F?
4D,
Why? Why 4D?
because the displacement come before the overbite.
Yeah, displacement come before the overbite. So this patient, even they have two features, we go for 4D. 4D. Agree, huh? Okay. Next case. How about this? Count the number. Okay, 1, 2, 3, 4, 5, 6, 7. Left side, 1, 2, 3. Oh, 3 missing. Canine is not there. Then the rest is okay. This one okay, okay. You have a decidus. Decidus not counted unless they are submerged. So this one not submerged, we leave it. Then we have impacted canine, maybe. We cannot see the X-ray, but we assume the worst. Like I say, without any clinical information or investigation, we assume the worst. So this one you see have palatally impacted canine. Okay, all right. We have impacted canine, which will give you
5I.
5I. Okay. So let's say without this impacted canine, what are the things you can get? You can get the displacement between the lateral incisor to canine. This one may be able to give you 4D. Yeah. Without this missing canine, maybe you get 4D. Or you can talk about open bite between the incisor and the canine, or this canine to the premolar. So this one overbite can be problem, displacement, impacted. So we have three different malocclusions. Based on the motto and the grading, then I think we go for 5I. Agree? 5I?
Yes.
Okay, all right. Oh, okay. Okay. So how about this? This patient have a severe skeletal castry problem, then complicated by asymmetry, reverse overjet, 8 millimeters, bilateral crossbite with the mastically problem, eating problem. Yeah. So what are you going to get for this case?
5M.
5M. Why? Because they have problem eating.
Yeah.
Eating problem. So if without this eating problem, what score you get? Let's say without this masticatory problem, then what's the score you get?
4B.
Yeah, 4B. So 4B, if there are no problem for speaking, oh, sorry. Okay, something wrong. All right. So no problem, then we give them 4B. A problem, we give them 5M. Okay. All right. So this one deep overbite, complete the palate and causing indentation to the gingiva. Potentially trauma. Trauma to the palate gingiva. Okay. So maybe we look at the number first, count the number. Everything is present. Okay. Then we go for the malocclusions. So the patient have deep bite. Maybe we give you a 4F. Then we have the displacement. Okay. They don't argue. Maybe more than 4 millimeters. They give you 4D. You got 4F and 4D. Maybe you can argue this one have an open bite or so. Maybe give you 4E. Okay, so between all these, which one you choose?
4D.
4D, why?
Um,
Mocto again, huh? Mocto again. The bite will come after displacement. Huh? We go for displacement, maybe it give you 4D. Agree?
Doctor, if how it got 4E and 4F, just choose F.
4E. The F is maybe the deep bite causing trauma to the palate. And the 4E might be due to open bites more than 4 millimeters. Yeah.
But
Okay.
so to
Yeah.
choose which one, if got 4E and 4F.
4E and 4F is the same category. Open bite and deep bite is the same category. It's an
So
overbite problem.
so anything is fine.
Yeah, anything is fine. But in this problem, this case, we have other problem, displacement. So maybe we'll go for 4D rather than the 4F and 4E.
Yes,
Yeah.
yeah.
And this one, I think you didn't measure. Maybe the overbite is not that severe. Maybe just more than 2, but less than 4. Maybe give you a 3E, maybe. Yeah. So I think in this case, we go for 4D. Agree? Agree, yeah? Okay,
Yes,
next
yes.
case. Okay, how about this? This patient have cluster deep 1. Then we have the deep bite also. The upper right, we have the retained C. Then we have an unerupted 1-3. Maybe impacted. But look at the space. The space is more than 4 millimeters. So just now we talk about impacted. It must be have a crowding less than 4 millimeters. Then consider impacted. In this case, maybe they are not erupted yet because they have decidus. It just aspirated on the left side. The right side is not erupted yet. But based on the case, maybe we cannot consider as impacted because they're not the time for eruption yet. So in this case, what do you think? Maybe the overjet. Overjet maybe class of deep ones more than 6 millimeter, less than 9. We give it 4A. If more than 9 millimeters, then this patient might score 5A. Then maybe you're talking about the deep bite. Look at the upper palate. This one consider damage or trauma. There are indentations or maybe causing a bit of gingival stripping on the palate, the 1-1 and 2-1. So this one consider 4F, 4F, traumatic, deep and traumatic. So overjet is 10 millimeters, then overbite maybe give you 4. So the overjet will come before the bite, because this one category 5 for the overjet. Even they have deep bite, consider 4, which is not too bad. So this one maybe we'll go for 5A. Agree 5A?
Agree.
Agree.
Doctor, for the
Okay.
missing
Yeah.
tooth,
There's a missing tooth? Where?
no, the canine lah.
Oh, the canine. The canine
Ah.
because it's not the time aspirating yet. Look at the left side. This one, the canine is just aspirated. The right side, maybe give you another 6 months, maybe it'll come out. And just now we already talked about impacted teeth. They must be have less than 4 millimeter space. So this one, I think, is more than 4 millimeters. And looking at the age, maybe it's not aspirating yet. So I think maybe this one we won't classify as a 5I. Maybe we're not classify as a 5I. So I say 5A may be more appropriate for this case.
Okay, doctor.
Okay. Okay lah. Okay. Maybe you can argue maybe 5I lah, if they are impacted. But I just think 5A, based on the situation, be more appropriate. So this one is 145. Okay. All right. Okay. How about this? Has 3 scatter pattern, crossbite, 1, 2, 3 on the right side. Then maybe we have displacement. Yeah. Then we have crowding, severe crowding on the right side, upper right, rotated lower. Okay. So what come into your mind for this case? You have a crossbite, maybe with displacement. We don't know. We just assume maybe the displacement. And this crossbite maybe is 1 to 2 millimeters. So or more than 2, then we give you 4C. Less than 2, maybe give you 3C. And we have crowding, severe crowding, maybe give you 4D. Then what else? Okay, the incisor, because they are not all in the reverse bite, so we wouldn't consider this as a reverse overjet. Must be 4 incisor in the reverse overjet. then we can measure the overjet, reverse overjet. So this one, maybe severe crowding, we give you 4D. Then
Yes, doctor. I think for
yep, 4D, yeah? Okay, 4D. All right. Okay. How about this? Class 2 deep 1, overjet 8 millimeters. And have a deep bite with a gingival indentation. Gummy smile. Gummy smile score anything? No, score nothing. Gummy smile. So we look at the bite, maybe deep bite, or maybe we give you 4F, deep bite. Then this overjet is more than 6, then less than 9, then maybe we give you the 4A. So maybe 4A and 4A and 4F, which one you go for?
4A.
4A, yeah, because the overjet will come after, come before the overbite. So in the same category 4, then I think we give this patient 4A. Agree?
Yes, 4A.
Okay. All right. How about this? Okay, cross rep. Do you want to do this? So first thing first, count the number. Count the number from the occlusal view. 1, 2, 2 is missing. 3, okay. This one 4, 5 maybe coming through later. This on left side 1, 2, 3, 4, 5, 6. Okay. Bottom 1, 2, 3. Okay. 4, 5. It's not erupted yet. Maybe it's missing. This one extracted before. So you see this one have class 1 incisor, space upper and lower arch. Spacing score nothing. Huh? Missing upper right 2. Missing upper right 2. Lateral incisor from the X-ray is not visible. This patient have congenital missing upper right 2. So I'm going to give you this one. Only 1, 2 missing. Yeah, 4H. Huh? Because there are 1, 2 missing on one quadrant. So I give you 4H. It's more than 2, more than 1, then we give you 5H, huh? Based on severity. Okay, I agree this one is 4H, huh? 4H. Okay, how about this? So this one we have first thing first, always count the number. So count the number first. You see this patient have a 1, 2, 3, 4, 5, 6, 7, 8. Sorry, 7 on the right side. Left side 1, 2, 3. 3 is missing. Have impacted canine. So this patient, if based on the impacted canine, then maybe have a 5i. Yeah, but if you look at the lower, they have a full set. Okay, all right. And this one partially erupted, maybe tilt against the lateral incisor. This one maybe you can get a 40, tilted. So between the 5i and the 40, I think we go for 5i. Agree? 5i, impacted canine? Yeah. Simple, huh? Simple. How about this? So this, based on this case, again, same thing, count the number. There's our full set present, no problem. Then look at other crowding. Canine open bite, maybe give you a 4E. Severity of the open bite is more than 4 millimeter on both sides, okay. Then displacement, no, crowding, maybe you have a 4D on the canine. So maybe 4D and 4E. Okay. So when it comes to bite and displacement, then we go for displacement. So for this case, I will choose 4D. Agree?
Yes, 4D.
Yeah, agree.
Okay. All right. How about this? You want to try? Idiot, do you want to try this one?
Yeah, hold on.
Okay. Yeah. Go ahead.
I'm thinking of 4D.
4D.
Yeah.
Displacement, crowding between the lateral incisor and the canine. Okay, it's good thinking.
Yes,
Okay,
because
maybe crowding.
because I'm seeing crossbite, but I'm thinking
Okay.
that would be a 3C.
Okay, yeah, maybe 3C or 4D. Huh? So I think I agree. I go for 4D. Even not this lateral incisal. If you look at the lower crowding, also maybe I give you about 4D. Huh? So I think 4D in this case. Huh? 4D. Okay, how about this? Simple. Huh? Cleft and palate straight away. They give a 5P. Huh? 5P. So there's no doubt. Huh? Everyone see cleft straight away. 5P. The most severe one. How about this? Count the number first. You have all the tear present, okay. But you have a crossbite, bilateral crossbite, castry incisal, but not involve all the incisal. This left incisal is the positive, overjet, overbite. Then the right side, maybe you have a crossbite on the 1, 2. Then this one buccally displaced canine. So crossbite maybe this crossbite have a negative 2, maybe it give you 4C, okay, I assume the worst. Have the displacement, 4C. Then this one have a 4D. So what do you think? We have 4C and 4D now. Yeah, which one you go for?
Crossbite.
Crossbite, yeah. Maybe you have a displacement, you have crossbite. If not, then you go for 4D. I'm okay also. Huh? If without displacement, then maybe you go for 4D. Yeah. Okay, this
Doctor,
one.
one question.
Yeah.
Not like 4L, right? Lingual crossbite,
4L,
which means
yeah.
the scissors bite, is it?
Scissor bites, yeah. Scissor bite.
Okay.
Scissor bite is 4L, huh? Lingo.
Okay.
I remember L is for lingo.
Okay, understood.
So this one, simple. It does a 5P, huh? Everyone agree, huh? 5P, clef. How about this? Overjet 6 millimeters with competent lips. Crosslap, do you want to try this? Overjet 6 millimeters, competent lips. What score you can get?
4A.
Huh? 4A? 4A?
Yes.
4A? Why 4A? What's the definition for 4A?
More than 6, that's a 9 for each line.
Yeah, this one
3A.
overjet 6.
So
And
it's
some more this one with competent lips. The 4A usually not competent lips.
4F,
4F, why? Why 4F?
there's a deep bite.
Yes, deep bite, yeah. Then what else? Deep bite is not good enough.
I'm
Gingival.
not sure if that's the stripping.
Yeah, there's an indentation of the gingival palate, palate gingiva. You see, there's a potential trauma. So this one we can get 4F, okay, agree. Then the overjet, even though 6 millimeters, competent lips, then maybe we give you only 2A. Yeah, 2A and 4F, which one you can choose? 4F. Agree? 4F?
Yes.
Okay, good. All right. How
Doctor,
about
sorry.
this? Yeah.
The gingival stripping, how can I properly visualize it? Because sometimes it's a bit ambiguous to like see the.
You see, the stripping is.
Yeah, I saw previously there was
Yeah.
one where the
Stripping
cementum was exposed.
Yeah.
How do like?
Okay. Doesn't
do I
matter
look-
they're stripping or not. The key is traumatic bite. The key is traumatic bite. So even though they are not causing stripping yet, but they are considered traumatic for this patient because they see the indentations. I mean, they're impinging on the gingiva or the gum. So maybe in long term, they will cause trauma, even not at the moment, but they're causing indentation. That's considered traumatic bite. Yeah?
Yeah. Okay.
Of course, you can argue they are not causing trauma yet, doctor. Why you consider a traumatic bite? We can argue this, but I consider this as a deep bite with traumatic potential. So I still classify this as a 4F. Yeah. Okay. Okay. How about this? Simple case. So this one, first thing, count the teeth. Basic always come first. I told you many times, the number is very important. So you count the teeth first. If you miss this number, you might fail your exam straight away, without any doubt, because you cannot count the teeth. So see the top, 1, 2, 3, 4, 5, 6 on the right side complete. The left side 1, 2, 3. The 3 canine is not there. So this one can be impacted canine. Impacted canine will give you the score 5i. Yeah. Even though this crowding 4D, whatever, deep bite, maybe not too bad, but this impacted canine will give you 5i. Agree? 5i?
Agree.
Okay, good. So about this, they have a narrow arch. Again, same thing. Count the T, 1, 2, 3, 4, 5. Oh, 5 is not there. Then 1, 2, 3, 4, 8. 5 is not there. So these are missing 2, 5. And how about the lower? Lower, okay. 1, 2, 3, 4, 8. The 5 is impacted. Not completely, partially. Then they erupted. So based on the lower, maybe it give you 40, 40. Impinging or impeded against the next two. Partially erupted. So this one give you 40. But the top one, I don't have an X-ray. So I assume the worst, maybe that's impacted 5 inside. So the top one maybe will give you 5i. The bottom maybe will give you 40. Agree? So if you X-ray, you'll notice there are no impacted 5. They're congenitally missing 5. Then maybe we give you 4H. Because only 1, 2 per quadrant.
Doctor,
Yeah.
the reason why you give 40 for the lower is because the crown is exposed, is it?
The crown is already visible. Means the 2 is
okay,
considered
okay.
partially erupted. They're not impacted. If you cannot see the crown at all, when you take the X-ray, you notice that the 2 inside, that's considered impacted. So you see impacted and partially erupted, you have to be careful. Impacted, it means I cannot see the 2 at all. That's 5i. If they're erupted, there's just not enough space, then we consider 40.
How about 4H?
4H is a missing 2. So if you take the X-ray, there's nothing inside. So you get this top, the 5-year suspect may be impacted. But once you take the X-ray, there's nothing inside, missing. Then that you consider 4H.
So this case can consider as 4H, right? Because no X-ray.
Yeah, you can. Yeah, until you are verified or you're confirmed. We can argue this one is 4H or 5H, 4H or 5i. But because I don't have an X-ray between the 4H and the 5i, I choose 5i because 5 is more than the 4. Agree?
Okay. Yeah, okay.
Yeah, always go for the worst. If you don't have any X-ray backup, go for the worst. Okay, how about this? So this one, we just have the supernumerary or retain central incisor decidus stuck between the permanent incisor, then causing the crowding. Then this crowding maybe give you 3D or 4D. Then this one maybe I'll consider this supernumerary, maybe give you 4X. Yeah, 4X, agree?
Yeah, agree.
Okay, 4X. So if this is a space without this 2 in the middle, then patients score nothing, but just the crowding on the right side.
How about 5i?
Yeah, can be, because you forget to count the T. Maybe there's an impacted 3, maybe. Yeah, and the bottom also, because these are decidus, so many decidus, if I'm missing T. So maybe 4H, 5i, if you have 2 missing T, maybe 5H even. Yeah, I agree. Yeah, maybe you can go for 5i, 4H, or 4X until you have an X-ray done. Agree? Okay, maybe you go for 5i. Yeah, if you have impacted too.
Okay.
How about this? Again, first thing, always count the T. See the top right? 1, 2 decidus, maybe it's still young patients. 4, 5, this one can take X-ray. Left side 1, 2, 3, then 4, the 5 is not there. And look at the bottom, okay, same thing, 1, 2, 3, 4, 5 on the left side. Right side 1, 2, 3, 4, the 5 is gone. So maybe like you say just now, we can assume it's an impacted 5 or impacted 3, or maybe you give this patient 5i. We're talking about maybe missing T. Then patient may give you a 4H. Yeah, agree? Either the 4H or 5i. for this case.
Yes, agree.
Okay. Okay, maybe you're talking about this impacted, lower left tree impacted, they are partially erupted, then against the adjacent two, this one might give you 40. Huh? These features might give you 40. Okay, how about this? So this patient again counted 2, even though they're severely rotated, 2, 5. This one consider crowding, then this one also displacement, consider crowding. And you count the T, 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6. The bottom, 1, 2, 3, 4, 5, 6, right side, no problem. Left side, 1, 2, 3, 4, 5. 5 is not there. Then we jump to 6. So we can assume this patient have an impacted lower left 5. So that will give you 5i. Or if you take the X-ray, the 5 is not there or extracted before, then we can go for the 4D, which is the displacement or crowding. So either the 4D or the 5i until you have an X-ray done. Agree?
Doctor, why isn't it 4C?
4C, crossbite. Yeah,
Ah.
can be 4C. Yeah, but we are talking about Mokdo, then 4C will come later. So missing T will always come first. Yeah, agree. If you are 4D and 4C, then maybe you can go for 4C if that's the displacement. If that's the displacement, yeah, more than 2 millimeter, then you can go for 4C.
So meaning if I see a missing teeth, I can just say 5i and I'm not wrong lah, because
You're
without
not
X-ray
wrong
I can't say
until
anything.
until you're proven. Until
Okay.
you're proven. So this one maybe you're right. Maybe 4C, then 4D or 5i until you're X-ray done. Okay. Any questions so far? Before we go for your cases, IOTN calibrations. So far, okay, the revisions?
Yes.
Yeah, okay.
Okay, good. So now I need you to open your slide. Then look at your answer before we talk about the 30 cases. Yeah, maybe we'll take 1 minute break before we go for the cases. Yeah. Okay. Hello. Is everyone back?
Yes.
Okay. All right. So this one is supposed to be a interactive section. Oh, so I think from the rest of the sessions, I hope some of you, if not all, can join in for the discussions, because I always hear only one or two voices. So maybe this time you take initiative, even though you are wrong, it's okay. As a student or dentist, we always learn from mistake. It's okay to make mistake. As long as you know what's a mistake, you can correct it later. Okay. So first case. So this case, we know we have a cross bite on the 2-1 and 2-2. Of course, we have crowding on the central incisor between two central incisor. Okay, so maybe this cross bite, we don't know we have a displacement or not, but maybe we just assume the worst. They have a discrepancy more than 2 millimeters. So this one maybe have a cross bite problem and a displacement problem. So what do you think? The score?
4C.
Yeah, 4C, I will take it. 4C, have a cross bite displacement, maybe. What else?
So I put it at 3C.
3C, okay. 3C accept because we don't know yet. Maybe they're just 1 millimeters, we don't know. Yeah, maybe you can try 4D also because they have displacement between a central incisor. Contact point displacement more than 4 millimeter, that will give you 4D. So if you have 3C and 4D, then maybe you go for the 4D, even though the motto is C crossbite come first. But based on the severity, 4 will more severe than the 3. So I'll go for 4D. If that displacement is more than 2 millimeter, it give you 4C and 3D. Maybe I'll go for 4C. But if you think this one is 3C, so between 3C and 4D, then we should go for 4D. Agree? Or anyone have different answer? We can always set it out. Then we can talk about it together.
After the displacement, you meant which tooth?
Displacement is between the incisor. You see there's a cross bite on the 2-1 and 2-2. Maybe this patient can bite, have an initial contact on the 2-1 or 2-2, then before the lower teeth slide forward or left. There's a considered discrepancy between the ICP, intercuspal, and the RCP, retrograde contact position. Yeah.
Yeah.
So when you have crossbite, always check for initial contact with or without displacement. Very important. So if a crossbite with a displacement or there's a functional shift, then you have to intercept early before this one set in and affect the growth for the patients. Okay, so case one agree, maybe we'll go for C. Yeah. Go ahead.
Obviously, this case is crossbite.
Yeah.
But we choose displacement because displacement come before crossbite, is it?
No. We choose displacement because the displacement is 4. Then the crossbite may be 3, like your colleague said just now. So, but if the crossbite is more than 2 millimeter discrepancy, then you should go for the crossbite rather than the displacement. Because according to motto, crossbite will come before displacement. So let's say 4D and 4C, then I go for 4C. But 4D and 3C, then of course we go for 4D. Does that answer your question?
Okay. Thank you.
Okay. It just depends. We come for the number first. 4 and 3, you choose 4. 4 and 2, you choose 4. So the 4 should come before the 3. Go for the most severe. But if the same severity, grade 4, then go for motto. If they are conflict each other, same severity, grade 4 or grade 5, then you go for motto alphabet. Okay, grade 2. Case 2. Who want to go for this case? For this
4A.
patient, 4A, 4A, agree. Maybe 4A, we don't know yet. But this one, I think, is more than 9 millimeter. The OJ look quite severe to me. Yeah. So how do I know? I will take the incisor. I take the canine. The canine width about 9 millimeters. So you look at the canine and the overjet. I think the overjet is more than the canine. So I think this one should be more than 9 millimeter, the overjet. Yeah, you're right. I don't know. Yeah, until I measure it. Based on the experience, I think this one is more than 9 millimeters. So if more than 9 meters, I think it will give 5A. If less than 9 millimeters, then more than 6.5, and maybe I give 4A. Yeah, I agree. Overjet is a problem. What else? What else I can give this patient? Displacement. Yeah, displacement maybe will give you 4D. Yeah, then you're talking about the number. Yeah? Maybe give you 5I. Which one?
Lower left premolar.
Yeah, lower left premolar until they are proven by the X-ray. Then how about this? Bottom right? Impeded lower right 5 or partially erupted, impacted
40.
lower right 5. Yeah, 40. Oh, so there are so many features. Huh? So you can always argue which one is more severe. So maybe based on severity, I'll go for 5A or 5I. Even though there are 40 and 40. Yeah. Maybe you can choose between 5A if there are no missing T, there are no impacted T, or 5I. Of course, you can argue how about this lower left 5 is missing. Then that will give you 4H. 4H is still not comparable to 5I or 5A. Huh? So I think if you give me 5A and 5I, I'll take it for this case. Yeah? Agree?
Okay.
Okay, yeah. Thank you. Say something. Okay, case 3. I think we have to be a bit faster. I think we're running out of time.
Sorry,
Okay.
doctor, one question.
Yeah,
If there's one case that has like one missing tooth and a partially erupted, where does that fall?
Yeah, good questions. I would say they're both okay. Even if you give me 4H and a 4T, they're still considered number. Yeah.
All right.
So when the category same, I think they're okay. Both are okay.
Okay, thank you.
All right. So number 3, this one, I think I would do it. This one. Okay. So this patient almost perfect occlusion, mild crowding. Maybe you can argue they are not perfectly class 1 on the left side. So you see the right side perfect class 1, interdigitation is perfect. But the left side, they are not perfect. They do have the zigzag interdigitation perfectly. But the center line is a bit off. This one doesn't count. Alignment, not bad. They're almost perfect. So it's just on the left side, they are not perfect interdigitation. So what will give you this one?
1.
2E.
1 what?
2E.
1D maybe, 1D, 2E. Why 2E?
The open bite.
Where's the open bite?
Millimeter.
Tell me where's the open bite?
2G, doctor.
2G? Yeah. I would say this one is 2G. Open bite must be no contact between upper and lower. Even though this left side, we have a tenuous overbite, but this one doesn't consider open bite because you see the incisor edge, you consider touching the lower. Yeah?
Okay.
So if the two, they are overlapping, or even though they're edge to edge, they're not considered open bite. Open bite must be the space between the upper and lower, cups to cups, incisor edge, or the buccal cups. So this one, I would say maybe, you're right, 1D, slightly displacement, mild crowding, very mild. But maybe I will give 2G, because between the 2 and 1, I'll go for 2. So buccal segment not perfect, then they give you 2G. Yeah, 2G this one. Agree? 2G? Okay, no answer? I assume you're okay.
Doctor, why not 1?
Because
not 1.
2 and 1, which one you want to choose? Of course, you choose 2. 2 is more severe, isn't it? I say 5 and 4, you choose 5. 4 and 3, you choose 4. Now you have 2G and 1D. Which one you choose? You choose
So,
2,
doctor, does it mean that we always have to grade a more severe one if we are not really sure?
Yeah. You always go for the most severe. That's what I'm talking about for this whole lectures. 5, 4, 3, 2, 1. You grade always the most severe one. You go for the most severe. You have 5, why you want to go for 4? You have 3, why you want to go for 2? You have 2, why you want to go for 1? So in this case, you can argue you have 1D displacement a little bit, but I have 2G in my hand. Of course, I go for 2G because 2 is more severe than 1. Get it? Yeah.
Doctor, you said 2G because the lateral incisor don't have a perfect interdigitation, is it?
No, because
Then-
the left buccal occlusion. You see my? Can you see my cursor? The left.
Yes.
Yeah. You see the right side. This class 1 canine, class 1 molar. Then every one zigzag. No, every 2 is a zigzag position. Then the cups is fall into the embrasure. Upper is fall into the embrasure of the lower. This right side is considered perfect buccal interdigitations. Agree, Susan?
Yes.
You see the left side? The left side, you see the class 1 canine, maybe it's not there. Oh, it's not canine class 1. This one slightly class 2 canine, then slightly class 2 molar. Then this interdigitation is not in a zigzag position. So the buccal cups doesn't fall into embrasure for all the teeth. So this one doesn't consider perfect interdigitation. So this will give you a 2G. So you go back to your chart, the 2G, it means you're up to half unit of discrepancy of the malocclusion. So this will give you 2G.
Okay, understand.
Agree? Agree, huh?
Agree.
Okay.
Sorry,
Okay. You're confused? Confused between the 2 and 1. Is it?
what's the meaning of pre-normal or post-normal occlusion?
Pre-normal and post-normal.
Ah.
This one, I think it just means before and after braces. Before and after braces. Yeah.
Okay.
It's okay.
Oh,
Forget
doctor,
about
because
this
that
pre-normal
one
or
is
post-normal. Yeah.
that one's the
Yeah.
definition for 2G.
Yeah, 2G. 2G means it's just imperfect buccal interdigitations up to half unit after class 1 and class 2 or class 3. When they are not class 1, they are class 2, half unit, then you consider 2G. Yeah. Okay, maybe I put it that way. If you don't have a class 1 canine, then but you have a class 2 or class 3 canine, up to half unit, then you consider 2G. Yeah, is that acceptable?
Yeah, okay.
Okay, all right, good. Okay, case 4. Anyone want to try this case 4? So this case 4, what I can see, only have a crowding on the anterior regions. Ventral incisor, retral incisor, and canine maybe a little bit overjet, not bad. Overbite also not too severe. So based on this crowding, I think mostly I can give about 3D, yeah, maybe between the lateral incisor and the canine, a little bit. Central incisor, lateral incisor, maybe 2D. So if more than 2 millimeter, less than 4 millimeter displacement between the contact point, then I give maybe 3D. Agree? 3D?
Yes.
Okay. If you say okay 2D, okay lah. Because I didn't measure it. I'll say okay. Okay, case 4. Case 4, I already give you a hint. Is incompetent lips. So this patient have an overjet, maybe not too severe. Maybe slightly more than 3, less than 6.5. But he has an incompetent lips. So if 3 to 6.5, then you consider 2A or 3A. But
3A.
because of the incompetent lips, we give it 3A. Agree? Agree, huh? Of course, you can argue this one, okay, a little bit discrepancy, crowding, then maybe give you 3D. But 3D and 3A, then we go for 3A. Overjet come before displacement. Huh? Okay. Okay, number 6. Yeah, number 6, simple this one, simple. Again, almost perfect class 1. Almost perfect occlusions. Slightly mild occlusions on the 1-1 and 1-2 displacement. Or you can argue this one again, the buccal interdigitation is not perfectly class 1 molars and canine. So this one, maybe both sides will give you 2G, and this one, displacement will give you maybe 2D, or if you're more than 2 millimeter, it'll give you 3D. So maybe I will go for 2D, this one, 2D, 2G, or if you want to argue, you measure perfectly, maybe more than 2 millimeter, give you 3D. Okay? Okay?
Okay.
Yes, yes.
Okay, huh? You not okay, say not okay, huh? Okay, K7. K7, very important. I say first thing first, count the T. So count the T first. Yeah. What you notice?
Missing lower lateral.
What? Yeah, say something. Missing lateral incisor, or maybe central incisor, I don't know. But based on the lower, there are only 2 incisor. That's why the overjet increase, because the top one you got a full set, the bottom you got 2 missing teeth. So you can argue with me, I think based on the overjet is more than 9 millimeters, give him 5A lah. I'll give 5A. Okay. If it's less than 9, then maybe give it 4A lah. But based on the missing teeth, maybe give you 4H. I'll say 4H, and if you overjet more than 9 millimeters, then give you 5A. But less than 9 millimeters, give you 4A. So 4A will take it, 4H will take it, 5A will take it. Agree?
Yes.
Yes.
Okay. All right. Okay. So number 8. Crossword wanna go? Yeah, crossword. What do you think this case?
I write 5A
Yeah, why 5A?
because the overjet is more than 9.
Yeah, good. So this one is similar to the K7, but this one have a full set of teeth. It's only the overjet problem. So based on the size of the canine, it's about 9 millimeter. Like I say, this one is more than 9. Definitely more than 9. Huh? So severe overjet 5A. Severe overjet 5A. Huh? Okay, now we go for number 9. Number 9. Yeah. Who want to take it? Number 9.
3F.
3F? Maybe you're right. It's more than 3.5, then complete overjet, complete overbite, but not causing any trauma yet. So okay, maybe I'll take it 3F. Yeah. Any other answer? Then maybe you can
2G.
argue on 2G. Yeah, maybe you can argue 2G. Yeah. Okay, maybe. Unless you measure the overbite. Huh? If the overbite is deep, complete, then maybe we consider 3F. If you are not complete, then maybe we consider 2F. 2F, 2G, 3F, I'll take it. No problem. Yeah? Agree, huh? Okay. Now we go for number 10. Okay, this one again, you see I already give it a hint. It's a high problem, speaking and eating. Reverse overjet. This one don't tell me it's not more than 3 millimeters. Huh? This one is definitely more than 3. Yeah, 5M straight away, 5M. Because I have problem with eating. If no problem, eating and speaking, 4B, yeah?
4B.
4B, yeah. 4B, if you no problem with eating and speaking. 5M, if a problem speaking and eating, yeah? Okay? 4B or 5M, but based on this description, it's 5M. 11, okay. So who will go first, this one? Basic. Go for basic.
3D.
Why? He didn't listen to my hint. I say go for basic. What's the basic?
4H.
5I.
Yeah, I'll take it. 5H. Okay, missing. Okay, maybe impacted until we have X-ray done. Which one is missing?
1-3.
Yeah, 1-3. That's why I said don't jump into conclusion first. Always follow the step-by-step basic. Do your checklist. If you have a checklist, then you never go wrong. I would say when you always go for the checklist, the number always come first. You see motto, missing T always come first. So always count the T as a first step. Then you won't miss out any missing T. So you see the upper right, there's a missing T 1-3. Okay, maybe impacted, maybe missing. So I say 5H, 5I and 4H possible. Agree? Of course, you can argue this one, hey, doctor, this one 4D lah, 4D. Okay, maybe 4D, but because I'm impacted, maybe I'll go for 5H. Okay, 5H, 5I, 4H, 4D. Okay, no problem. Take it. But 3D. Just someone mentioned 3D. I think this one is more than 3D. Huh? You see this one lateral incisor and a canine. This one definitely more than 4 millimeters. How? How you make sure? Because one incisor, lower incisor, is about 5 millimeters. So imagine you put this incisor rotated 90 degrees. You're not going to touch this canine. So I think this one definitely more than 4D. Huh? More than 4 millimeters displacement contact point. So 4D, 4H, 5I. Okay? Okay, huh? All right. Okay, number 12. I think the rest, I think I will do it. Huh? If you disagree with me, you raise your voice, huh? You sound something. Huh? If not, I just run through all the slides. Huh? So this one again, first thing you count the number. Okay, the all T present, no problem. So you have a bit overjet. Again, I say you use the canine as a guide. Then this one maybe, huh? Maybe you can argue less than 9 or more than 6. Okay, maybe I give you 4A. If you're more than 9 millimeters, then I give you 5A. Oh? Okay, mid displacement a little bit. Then this one crowding doesn't score anything. Yeah, I would say 4A or 5A after you measure it. Then you give me either the more than 9 or less than 9. So overjet is a problem for this one. I give you 4A or 5A. Okay.
Doctor, sorry, that
yeah,
case just now, the overbite, would you, I mean, I know overbite wouldn't overrule the overjet, but the overbite, would it be 3F?
Yeah, this one maybe 3F or 2F.
Okay.
Because you see the overbite is not too severe. Then I doubt this one is complete overjet.
Okay.
But you have to check. Yeah, you can argue this one is 3F or 2F. But we have 4A and 5A. I will go for 4 and 5. Yeah.
Yeah, okay.
Okay, so this one number 12 again. Individual number 12. This one done already.
Yes.
This is done. Okay. Yeah, 5A. Okay. Oh, yeah. You're talking about this, is it? Divide. Yeah, maybe. Yeah, this one maybe divide. Okay, this one. What do you think?
5M.
5P.
5P. Straight away. Cleft patients. You see the cleft is on the right side and the left side, maybe. You see the crowding is too severe. And jaw discrepancy, tendency of castry, typical after the scar tissue form. So all these are considered cleft patients. So cleft patients straight away you give 5P. 5P, yeah. 14. So this one again, this patient have a overjet problem. Then maybe this one between 6 and 9. So maybe we give about 4A. Then talking about the displacement, maybe we give you 3D. If more than 4 millimeter, give you 4D. Then have a little bit crossbite, maybe this one is a crossbite. Okay, maybe lateral incisor have tendency of crossbite with the canine. The discrepancy between 1 and 2, then 3C, more than 2 millimeter, 3C. Then lower this one crowding, maybe give you 2D, 3D. So yeah, I will give 4A like this one, overjet. Overjet come first. The crossbite maybe, but when we come to Mocto, the overjet will come first. So I'll go for 4A. If more than 6 millimeters, more than 9 millimeters, then go for 5A. Okay, 15. 15 is very simple. You see this one, overjet, not too bad. No, not too bad. Of course, first thing, okay, count the T. They're all present, no problem. When we count the T, auto, we don't include the third molar. This one I think we have mentioned a few times. I just want to repeat that. Third molar is not counted in auto. So we don't say impacted 5I for the third molar. We don't do that. We only count 7 to 7. Yeah. And we have a missing T also. We don't say the third molar is 4H. We don't count it. Third molar is not in our considerations. So this patient have some minor crowding on the top. Maybe give it 2D. Yeah. Okay. We argue this is more than 2 millimeters. Okay, keep it 3D. No problem. But we have an anterior open bite. The anterior open bite, we say how to measure it between the edge to edge. So this one may be between 2 to 4 millimeters, slightly more than 2, maybe less than 4. Then we give you 3E. It's more than 4 millimeters, then we give 4E. So this one maybe 3E, 4E. Yeah. Okay. I accept. Yeah. Agree?
Agree.
Okay,
Yes.
16. 16, okay, we have quite a lot of problem. Huh? So we count the number again. Okay, got full set, no problem, nothing missing. And look at the crowding, it's quite severe, rotated. Then we have displacement between the central incisor, lateral incisor, severe crowding. So this one definitely 4D. 4D. Then of course you can argue, doctor, this one I have a crossbite on the left side, lateral incisor. Okay, maybe more than 2 millimeter between the ICP and the RCP. And okay, then this one will give you 4C, 4C based on crossbite. So this one maybe give me 4D, 4C. Okay, I take it. 17, this one again, very simple. Oh, you see this one just now, someone asking me, scissor bite or lingual crossbite. So, sorry, not lingual crossbite, scissor bite. Scissor bite or lingual crossbite, same. So this one, the whole segment, you see, involve the whole segment in scissor bite. Upper, inside, upper molar is over erupted, then touching the buccal mucosa. So this one, again, is a traumatic bite. But these features, we give you 4L, lingual crossbite or scissor bite, almost the whole segment without any functional occlusion. So you want to know, scissor bite, they consider the most difficult malocclusion to correct for braces. You see how much the lower jaw is narrow, everything they push in lingually, then the upper is everything is go outside, push buccally. Very difficult to correct. A lot of time this one will correct by surgery, but now we have tack mini screw, so we can do more without the surgery. Okay, this one 4L, 4L. 17 I give 4L. Okay, 18, same thing, count the T, okay, no problem, nothing missing. Then occlusion, okay, not bad. Overjet, not bad. Overbite, not bad. Crossbite a little bit, maybe this displacement, maybe give you 3C. But this one, 1, and 1, 2, severe displacement. So I'll give 4D this one, based on the 1, and 1, 2. The crowding is quite severe. I give 4D. Okay, 19. Again, there's a hint here. You see, no problem for speaking and eating, even though they're reverse overjet, maybe slightly more than 2, or I don't know how many millimeters, maybe slightly more than 2, or more than 3.5, more than 3.5, but it's no problem for speaking and eating. So this one I give 3B. So if they have a problem eating and speaking, they maybe upgrade to 4M. This one more than 3, or maybe slightly more than 3. Okay lah. If it's less than 3, then 3B, more than 3.5, then maybe I give you 4B. Okay.
That's a good. So,
Yeah.
The overjet is count from where to where, from the incisor to incisor, is it, or from
incisor to incisor? Labial surface of the incisor to labial surface of the incisor for the most severe incisor. Yeah. So just now we say about the 40 must be in the reverse bite. So look at the lower incisor. Oh, sorry. See the lower incisor, there are 4 incisors involved. This one consider reverse overjet. If you're 1 to 2T or even 3T involved, then we'll consider crossbite, not the reverse overjet.
Okay.
So this one, number 20, again, I'll give you a hint here. This one, no problem. Yeah.
Isn't for number 19 just now, the lateral missing, upper lateral?
You're right. Yeah, you're right. Sharp eye, huh? So this one maybe the missing T will give you 4H. Yeah, 4H.
Yeah.
Yeah, maybe you're right. Yeah, 4H or he impacted, then maybe it give you 5I. For lateral incisor, it's very unusual they're impacted. They're usually missing. But canine, yeah, maybe they're impacted. Yeah, agree with you. Good thinking. Maybe this one 4H. Maybe, we can argue 4H. If there are lateral incisor present, then we will give maybe 3B or 4B. Okay, so this one 28, then we have no problem speaking, eating. We only have a reverse overjet. So this one again, measure the overjet. Based on the overjet, if less than 3.5, then maybe we give you 3B, then more than 3.5, 4B. If they have a problem with speech and mastication, then maybe you upgrade to 5M or 4M. Simple. 21. So 21 again, this one you have to look at number first. Okay, sorry. Okay, all the numbers are okay, correct, okay. And look at the overjet, slightly increase. This overjet may be slightly more than 3.5, sorry, more than 3, less than 6.5, then, or maybe if you measure it's more than 9, then maybe give you a 5A. If less than 9, then maybe 4A. The bite slightly deeper, then maybe you can qualify for 4F, 3F, depends whether traumatic or not. So I say maybe 4A. If you want to argue 5A, okay, 4F, okay, no problem. 22nd. So this one again, first thing first, count the number. 1, 2, 3, sorry, 1, 2 is there, 3 is missing, and the left side you got full set, then bottom you got a full set. So based on this upper right quadrant, I don't have X-ray. So assume this one may be missing, central incisor and the canine. So you got 2 T missing in one quadrant, then maybe you can qualify for 5H. So even maybe you argue this one dilacerated, I don't have X-ray, assume they're impacted, then maybe give you 5I. So 5I or 5H if you count the missing T, because we don't have X-ray, you can assume the worst. So 5I and 5H, okay, no problem. Because both also number, missing T. Mokto, the first one to come in, missing T. So 23rd, again, this one, multiple missing T. Definitely, without looking at the cast, you know this one is more than 2 T missing per quadrant. So straight away, this one qualifies as a 5H. 5H, multiple missing T. Oh, this one, very simple. Very simple. Look at the overjet. Massive, more than 9 millimeter. This one, definitely 5A. 5A. Okay, count the number first before make any mistake. Okay, number okay. No T missing. It's just the overjet problem. Again, this one is already say they have a mastication problem. Then this one reverse overjet. Maybe not too bad, not too bad, but maybe give you 3B. Because of this problem, eating, speaking, we upgrade to 4M. Yeah, 4M, or you want to argue 5M or 3M, okay lah, okay, no, not 3M. 4M or 5M, okay, based on the reverse overjet. Okay, this one competent lips. You see, I already give you a hint. Competent over lips. Competent lips. This one overjet problem. Overjet problem maybe less than 6, but because this patient have competent lips, then maybe we give you 2A. If they are incompetent lips, then maybe we give you 3A. 27, anterior mandible displacement. Okay, again I give you the hint also. More than 2 millimeters. Have a cross bite on the upper right too, and causing displacement about 2.5 millimeters. So this one maybe give you 4C because it's more than 2 millimeter displacement. If it's between 1 to 2, then maybe give you 3C. Okay, so crowding, maybe you can argue this one's 4D. Yeah, but the D will come after the C. Cross-bite come first, then the displacement come later. So I'll say 4C this one. Okay, if you know displacement, then maybe you can go for 4D if you're based on displacement or crowding. Okay, coming to the end, 28. So this one, again, count the number, everything's okay. All right, okay. Then we count for the crowding, maybe I give you 4D between the lateral incisor and canine. Look at the overjet, it's quite massive also. So this one maybe is more than 6 millimeters, but I don't think it's more than 9. Of course, I did measure it. If you're more than 9, then you give 5A straight. If it's less than 9, then maybe 4A. And the crowding, maybe you give 4D. Okay, if you give me 4D, 4A, I'm okay. If you want to argue, 4A should come before 4D. Then I will go for 4A. Even though they're same severity, 4, but A is the overjet. Then D is a displacement. Go for Mokto. Overjet will come before displacement. So go for 4A. 29. So 29 also again, same thing. First thing, count the number. Count the number. 1, 2, 3, 4, 5, 6. Okay. This one, what is that? This one, 1, 2, 3, 4, 5, 6. There's something extra in the middle. There's a supernumerary in the middle, causing the median diastema. So this one, I would say supernumerary is considered 4x. We're talking about displacement between the lateral incisor, canine, and the first molar. This one I give you 4D. So 4D, 4x, okay. But based on the motto, then x should come before the d because number. So supernumerary, 4x. So this case, 4x. Okay, last case. Finally, last case. So this one should count for the number again. 1, 2, 3, 4, 5, 6, 7. Okay, 1, 2, 3, 4. Okay, maybe the 4 is missing on the top left. And bottom also, we got missing 4. Maybe extracted, maybe infected. We don't know until the X-ray taken. So you can argue this one. Maybe if you're talking about this impacted, partially erupted lower left 5, then we give you 40. But if you're talking about missing 2, then maybe I give you 4H. So maybe 4H or 40. But I already told you 2, 4, 3, 4, 4, 1 extracted. So it should be 40. 40. Based on this, lower 5 is impacted partially. And the next 2 is already come into the space of tilting. So 40, because I already told you it's missing or extracted. Okay. Any questions?
Doctor, the last one, the extraction, let's say for, especially the extraction for 4, does that, do we take in consideration for the hypodontia?
Good questions. Yeah. So some lecturer will say if the missing teeth must be congenitally missing. So extraction we don't consider it as a missing teeth because they are not congenitally missing. But you can argue, if the patients not sure whether they have extraction done or not, then you consider 4H. If the extraction done, then there are no case. So you want to help the patient, you just write 4H. Who will know? Yeah.
Oh, so meaning if the patient tells us that like this was extracted specifically for like ortho, then we don't take that.
Yeah, we don't take that.
Okay.
If you're according to the definitions. But of course, like I say, you want to help the patient, you can argue patient don't know whether extracted before. So you consider missing. Yeah.
Okay, thanks.
But my advice is don't just focus on one particular malocclusion features. You have to look at the patient as a whole. You don't just go for 1 or 2 T displacement, then missing. You have to look at the whole malocclusion. Then you can know patient whether they need the braces or not. Yeah, that's why I say that's a limitation for this IOTN. But I hope after today, these IOTN calibrations, everyone will be clear about this IOTN. Because during the examination diagnosis sessions, I found that a lot of people are still confused about IOTN. So hopefully everyone get a better idea about IOTN. So I expect you can score better for IOTN after you come back.
Doctor, can I ask a question?
Yeah, go ahead.
For case 28, right? Shouldn't it be 4H? 28.
Okay, 28. 28 4H.
Yeah,
Why
because the
is it
lower
4H?
isn't the lower missing the laterals?
Yeah, you're good. Yeah, I missed that. Yeah, can be.
Okay.
Yeah, it can be 4H. Yeah, good thinking. Yeah, it can be 4H. See, even specialists also make mistake. That's why the basic always go back to the number. If you go this checklist, always count the teeth first. Before you do any checkup, always count the teeth first. Then you never go wrong.
Doctor, this overjet, is it considered 4A?
This one depends on how bad is the overjet. If the overjet is 6 to 9, then maybe consider 4A. If more than 9, you consider 5A.
Oh, okay.
Yeah. But just now your colleagues already bring out questions. If this one is 4H, I got 4A, then I go for 4H because I'm missing incisor on the lower. Yeah, good. See, sometimes lecture is not always right. If you're in doubt, you can always bring out the questions. Then sometimes you might be right. Any questions before we end this session? If not, I think, yeah, I will end this session. So sign your attendance. Then I'll see you soon, maybe next week. Okay?
Okay.
Okay, stay safe.
Thank you, Doctor.
Bye-bye.